Okay, we have to get started. For anyone who's in this room, we have to have a surreal experience, okay? The surreal experience is an abstract-driven session for 6 people in a room for 1,000 people. Anyone who wants to stay here is more than welcome. Those who are Dr. Martins, anyone who wants to leave may leave. We're going to have like a wonderful surreal experience. I've had this once before. But we have everyone here with Dr. Wang. Do we have Dr. Wang here or not? This is like a fantastic opportunity for practicing in front of if you've never given a lecture in front of a large group, this is a great practice. So why don't we get started? Okay, we're going to wait. We are going to do a session. Is Dr. Wang here? I'm missing Dr. Wang, but all the slides. Okay. We're going to get started right on time and finish a few minutes early. My name is Mike Cohen. I'm in charge of infectious disease and global health at the University of North Carolina at Chapel Hill. And I have had this surreal experience once before 30 years ago. So I feel like it's like a rejuvenation experience. So what we're going to do is talk about innovative approaches and technologies for abstracts that were submitted. Dr. Weintraub's not here, so we're going to have 5 abstracts. Each speaker, I assume, will talk for about 10 minutes and have 5 minutes for discussion. Did they tell you that? Okay. As is the tradition. And we will have our own lively discussion of the very small number of lively people who are with us today. So why don't we begin? And the first talk will be as follows. Can facility-based delivery boost infant vaccinations? The long-term impact of facility delivery in sub-Saharan Africa by Cheryl Moyer from the University of Michigan, Ann Arbor, Michigan, one of my alma maters. Please. Oh, okay.
Hello. This is very surreal, I have to tell you. I'm Cheryl Moyer. I'm from the University of Michigan. And before I start, I need to acknowledge my co-authors, one of whom is sitting right here, Dana Benyas, as well as Sarah Rominsky, without whom none of this would be possible. So my talk is on the relationship between facility-based delivery and vaccinations in sub-Saharan Africa. Clicking goes how? Technical difficulties. The clicker does not seem to be working. Next slide. Anyone? Okay. Was that me or was that someone else is the question. I have no financial disclosures or conflict of interest to declare. So let me start at the beginning. What is facility-based delivery? Facility-based delivery has been defined as births that occur outside the home in a healthcare setting. But for those of you who work in the developing world, you know that the term healthcare setting is incredibly broad. That can include anything from a health post to a tertiary care hospital. Any birth that occurs in any of those settings for the purposes of the research literature is typically called a facility delivery. And yes, there are huge methodological challenges with lumping everything together like that, but that's another talk. So what do we know? The first thing we know is that facility delivery is linked to higher rates of skilled birth attendance, and skilled birth attendance is linked to better health outcomes. We also know that despite some methodological challenges in the data, and despite some controversy, several studies have shown that facility delivery is linked to lower rates of maternal mortality and lower rates of neonatal mortality. So basically, in a nutshell, facility delivery is seen as a good thing. And it's seen as particularly effective at that window when moms and babies are at the greatest risk. Highest maternal mortality is right around delivery. Highest neonatal mortality is right around delivery. So facility delivery is seen as one way to minimize those risks. What else do we know? We know that facility delivery is linked to urban residents, higher education and wealth status. So in other words, wealthy, educated women who live in the city are more likely to deliver in a facility. Rural, uneducated women who are poorer are obviously less likely to deliver in a facility. One of the things we don't know is what is the relationship between facility delivery and future healthcare seeking, especially given that urban status, wealth, and education is linked to facility delivery. It's probably also linked to healthcare seeking in general. So what happens when we look at that relationship controlling for those factors? And that was kind of the genesis of this research. So the first thing we did is we looked at the percent of women delivering in facilities in sub-Saharan Africa using StatCompiler. And what you'll see here is that there is general increased facility delivery in southern and western Africa. So then the question came, what type of healthcare seeking would we be looking for? Clearly, postnatal care is an obvious choice. However, the rates of postnatal care are incredibly low, and often they count the first little checkup you've had 2 hours after you deliver as postnatal care. So that would be, by definition then, facility delivery would be related to postnatal care. So then we started thinking about some of the other more distal measures of healthcare seeking that a new mom might need, and we thought about immunizations. So then we mapped the percent of children aged 12 to 23 months who were fully immunized. And while the graphs aren't exactly the same, you'll still see that clustering of higher rates in southern Africa and in western Africa, which led us to the question of, I wonder what happens when you look at the numbers. So what did we do? We took online publicly available data from WHO, United Nations, demographic health surveys, the World Bank, and the IMF. These are country-level data, and we aggregated them into a data set looking at sub-Saharan Africa. Now, the indicators that we took included such things as percent of women delivering in a facility for the most recent birth, the percent of the population living in an urban area, the percent of the population with a secondary education, and gross national income per capita. And with regard to immunizations, the data that were available looked at BCG rates, which is an early immunization to prevent tuberculosis, hepatitis B, diphtheria pertussis, influenza B, measles, and polio. It also includes a variable looking at the percent of children who received at least one dose of all of those vaccinations. And for the purposes of this study, that's how we define, quote unquote, fully vaccinated. Now, the only good thing about having an audience this sparse is it decreases the likelihood that there's a pediatrician in the audience who's going to have an aneurysm that this is how we defined fully vaccinated. Because many of these require multiple doses, and there's all different schedules, and different countries combine vaccines differently, et cetera, et cetera, et cetera. This was a preliminary study. So for our purposes, that's how we defined fully vaccinated. So what did we find? We found data for 43 countries in sub-Saharan Africa, and I'm not expecting you to look at all these numbers. I realize the type is small. And what we found is 54% of women across sub-Saharan Africa deliver in a facility. In bivariate analysis, you will notice that BCG is significantly associated with facility delivery, which isn't surprising given that BCG is one of the first immunizations. But using a liberal p-value of 0.1, we also show that full vaccination is associated with facility delivery. But note also the confirmation of what I had said previously, that income, education, and urban status are also significantly associated with facility delivery. So then we conducted a couple of multivariate regression analyses. This first shows that facility-based delivery confers a 28% increased likelihood of BCG even when you control for income, urban status, and education. When we looked at full vaccination, controlling for income, urban status, and education, it might look like 70% increase in vaccination for those undergoing facility delivery. While the p-value suggests statistical significance, I'd just like to point out that the confidence interval suggests that this finding needs to be interpreted carefully. So what does all this mean? I think this preliminary analysis suggests that facility delivery is related to increased BCG immunization and perhaps to full vaccination in sub-Saharan Africa, even when you control for urban status, wealth, and education. But why exactly does that matter? And I think the take-home here is that facility delivery is often advocated for its immediate benefits to the mom and the baby, but there may be additional benefits that are conferred, including encouragement to continue care seeking in a Western facility. And yet, dare I not state the obvious to this group, correlation is not causation, so clearly further research that explores this association is warranted. Thank you. Did you want me to take questions here or take questions later? Yes.
I have a question about, not the conclusion, but about the meaning. So obviously you'd like babies to get vaccination, however you define it, and full vaccination would be preferable. The facility, and you identify this kind of facility phenomenon, which is not surprising. 54%, I think you said. So 46% are not using facilities.
Right.
So another way of looking at this is, how will you get babies vaccinated of moms who don't use facilities? If you
Right.
flip the question around and say, oh, we demonstrated there's no facilities, there's not going to be facilities in the near future, the real problem, one of the problems at least, beyond the first few days of life is the vaccination. Could you comment on that?
Right, I think that's a really great point. I think one of the things that these data obfuscate is that there are countries that have done a really good job with immunization campaigns, and those are also some of the countries that seem to be trending upward in their facility delivery rates. So I do think that the issues around immunization is one place where I think the neonatal community has done a pretty good job of trying to push immunization campaigns outside facility settings. There are immunization days where moms and babies line up for miles that I think is a marker for development. All of this went into, when we went into this research, the question that has been really troubling me is, we're trying to talk about individual actions that can improve moms and babies' lives, right? And yet so much of it seems like proxies for development. What is the economic development piece of this versus what is the better supply of facility piece of this versus what is the immunization campaign piece? So this was our first attempt at trying to disentangle those very entangled components.
Let me ask you one other question, and somebody else. Feel free to ask questions. This is a very sparse audience, a lot of work went in each of these presentations, so your courage to ask a question is really critical. Each person here should ask 3 questions. It's like, we'll make it a challenge, a challenge. But what is Michigan Global Reach? Could you explain what that is?
Okay. That's an easy one. So the University of Michigan has a international program out of the medical school which is called Global Reach. And REACH actually stands for Research, Education, and Collaboration in Health. It's run by Joe Kolars and me, and there's a team here from Global Reach as well. Basically, our mission is to facilitate research, education, and collaboration, not only within our faculty, but across school-wide faculty at Michigan and with our international partners. So our main partners are Ghana, Ethiopia, China, Brazil, India, I believe. Am I missing any? I think that's all of them.
I had a question. In
Yes.
your research, did you come across some of these public-private partnerships for birthing centers that are having an impact on the trust and access to facility-based births?
I confess that that's not an area I know a lot about. I know that it's an important and growing area. I think the role for NGOs as well as public-private partnerships is important, and I think it's one that needs to be explored, as we go forward.
Well, my question is on the amount or the percentage of women who attended the clinics. And among those, of course, you've told us about those who have delivered in the facilities.
Oh, for
Do you
antenatal
have
care.
any idea of how many attended the clinics but did not, or attended the facilities during the antenatal care, but did not deliver in the facility?
Yes. That's a
And
great
probably
question.
what would be the reasons why? Because as far as I know, the percentage of those who actually attend the facilities, antenatal care, is much higher than those who actually go back and deliver them.
Yes.
And there might be some reasons probably
Yes.
for that.
You are
Do have any
absolutely
idea
correct.
For such? Thank you.
That's a great question, and the research that we've done in Ghana bears that out, that there's, I think, 90-some-odd% of women seek antenatal care, whereas about half go for delivery. And some of the work that we've done has looked at the predictors associated with that. Lots of social and cultural factors that impact, lots of logistical issues, transportation, cost, et cetera, that I know at least Ghana is trying to deal with through national health insurance, but that still doesn't help when a woman is, 10 miles away from a clinic in the middle of the night, goes into labor, and there's no one to drive her. Or her mother-in-law doesn't want her to deliver at the clinic, even though she's gone for antenatal care. Or they have to pay the driver, and they don't have any money, and they haven't planned for it. So there are a ton of issues associated with that disconnect. We didn't include that in this particular analysis, but I think it's an important variable to consider as we go forward with further analysis. Yes?
Yes, my name is Rose McCauley. I'm a public health physician working in Liberia, and I've actually worked a lot in immunization. I have 2 questions. The first question is, of the number of, or the proportion of kids who were fully vaccinated, were you able to tell how many of them were vaccinated within the 11 months of life, which is promoted?
No.
That's the first question. The second question is, of the women who delivered in health facilities, what proportion of them were up to date with their own immunization?
Ah, that's a great question. Yeah, unfortunately, this is another situation where the quality of the data is a huge limitation. This is aggregate data available from WHO and other sources where they give you one statistic. And so we thought we'd look at this general statistic before we started trying to drill down a little bit farther. But those are great questions, because you're right. We were able to tell the number of babies 11 to 23 months who had been immunized, but not at what point, whether it was early or late. And certainly there was no information at all on the women themselves.
Thank you, Dr. Moyer. Thank you. Okay, now, following in Dr. Moyer's tremendous footsteps, we will hear from Wilson Wang, who will speak on the first use of intravenous artesunate in Liberia and effect on patient mortality relative to artemeter and quinine. He's from EMAS Jhpiego and Save the Children Indonesia, and I think this is him.
Well, thank you so much for you 20 people for coming to this talk. My name is Wilson Wang. I'm a pediatrician. I work with Save the Children in Indonesia. I'm a senior technical advisor for a neonatal and maternal survival project. If it seems like I might be dazed and confused, it's because I am. 48 hours ago, I was stuck in Jakarta traffic. When I came off the plane 28 hours later in DC, I was no longer the tallest, biggest guy around. In this talk, I'll be changing my hat to a time 2 years ago when I was the Deputy Director of Health for the International Rescue Committee, Liberia, so I know Rosie very well. And I'll also be not talking about neonatal mortality, but malaria, a disease that we don't see in the United States, but which causes, is the second leading cause of death in sub-Saharan Africa, killing at least 2 million a year. So I guess I'm just trying to say I'm rolling with it. And I was telling my colleagues that's perfect for this conference because that pretty much sums up a career in global health. So all you do-gooders, beware. The title of this talk is First Use Intravenous Artesunate in Liberia and Effect on Patient Mortality Relative to Artemeter and Quinine. In March of 2012, the Clinton Foundation approached the International Rescue Committee, IRC, and asked if we would pilot the use of artesunate in the two biggest pediatric facilities in Monrovia, JDJ and Redemption. Up to that point, the only anti-malarials for severe malaria were artemeter and quinine. And we were very excited at this prospect because we knew from the Aquamat study, a study of over 5,500 kids randomized across 9 countries, that artesunate was shown to be 22% more effective than quinine, the former standard. Indeed, in 2010, the WHO had changed its standard to make artesunate first line for severe malaria, but many, if not most countries in sub-Saharan Africa had yet to make the switch. And so we said yes. But like every good implementing partner, NGO, we decided to also monitor and evaluate as we implemented. And we wanted to ask essentially 2 questions. The first question is, could we change provider behavior? IV quinine has been used since from the 17th century. Would we be able to change provider behavior when we providers know it's hard to get us to change much of anything? We also want to see if indeed that we could decrease mortality from severe malaria because that was our end goal. So I'm going to be talking to you about this according to the following outline, but I'm going to presage and say that I'm going to spend a significant amount of time on background. It's just very relevant when you're talking about doing research in the field, and I think it's fair to you to give you an idea of what was the context of this research. Liberia is a really fantastic place. When I think about Liberia, I think about people, food, and rain in that order. The guy to the right is Agustin. I want to mention him because he is the second author on this study. There's no way we could have done this study without Agustin. He's standing with the families in our diabetes clinic, which he still runs even though our program ended long ago. These are just Liberian kids, very typical for Liberian children to run up on you and literally step on your toes to get to know you. Behind every large pile of rice in Liberia, I think, is a Liberian. Liberians love rice, and they usually put on it cassava and mixed with some fish paste. Mangoes literally fall from the sky. I once asked a driver, after eating many mangoes for many months, I said, "Do you Liberians ever get sick of mangoes?" And as soon as when he answered, "No," I realized how stupid my question was, coming from a place where there's so much diversity of fruit. Of course, people like mangoes in Liberia. Who doesn't? And it rains a lot. It turns out, no one told me before I was assigned to Liberia that Monrovia is the wettest capital in the world, 17 feet of rain a year. This presented some challenges during the rainy months because your internet would pretty much go out, and what sustained you through that time was the stories that the cable was finally going to get pulled down from France to allow for a better internet service. But Liberia is also a complicated place. It was started as a safe haven for slaves by President Monrovia in 1821, thus the capital's name Monrovia. In the 60s and 70s, it was really the gem of West Africa, and people would go there for vacation. And then starting from the 80s to 2003, it alternated between dictatorship and civil war. What this has meant is that a degradation of the systems and infrastructure and the government that is responsible for the maintenance of that system and infrastructure. And so you might have roads like this, and you would just think, what does this relate to how people get to their jobs, or how drugs are delivered, or how patients are transferred to the hospital. Education is not free. It costs $100 a year, and that pretty much means that a lot of people don't go to school, and then you have a cycle of people living on $2 a day, or when a well-qualified person coming to your institution might mean that they can do Microsoft Word and Excel. And finally, it's led to some brain drain. There are 150 between 200 doctors in the whole country. There are 5 pediatricians in the whole country. And so the realities are that the MMR is 770. That's per 100,000. So about 1 in 100 women will die in childbirth. The CMR is 75, 5 and under. That's not per 100,000, that's per 1,000. So that means, almost 8 kids will die before they're 5 out of 100, and the NMR is 31. Just as a test, do you know what the MMR for the USA is? 21. How about Singapore? 3. The CMR, USA, 7. Singapore, 3. NMR, USA, 4. Singapore, 1. If you ever need medical care, Singapore. When it rains, it pours, and it just happens that the only malaria strain that really kills you is called P. falciparum. And of course, it is the dominant strain, 95+% in Liberia. You'll see from the slide that 15% of Liberians will die of malaria in their lifetime. At JDJ, the source of this study, we see from the percentage of patients admitted to this busy hospital, 100-bed hospital, these same statistics. 43% will be admitted for malaria, 20% for pneumonia. If you did the math, 43% times 800, you would basically get about 15 deaths per month from malaria alone. I've been practicing pediatrics for about 12 years now, and in my entire career in the United States, I have not seen that many die. This is how malaria is traditionally diagnosed. It's diagnosed through smear. There's a very typical appearance of P. falciparum, thin rings of the immature trophocyte with a two-dotted appearance. Once these grow, they're going to burst the red cells. If they burst enough of the red cells, you can die of heart attack. If not that, then the debris from the cells can get caught in your kidneys and you can die of renal failure. And if not that, your body will engage in a full-on fight, and generalized infection can swell your brain. This is it's the gold standard way of diagnosing malaria because you can see what is the strain and you can see what is the load. But this test also takes about 15 to 30 minutes. So you can imagine that if you have 100 patients going into your emergency room, you'll incapacitate the lab. And that's why RDT, rapid diagnostic test, a 1-minute test, sort of you have it or you don't, has taken precedence. That is very important in this particular study because that is the standard in which the subjects are included. And finally, this is the treatment of severe malaria. You'll see that the old standard was very hard to deliver. Not only is it every 8 hours quinine, but it has to be in 5% dextrose. It's over 4 hours, and then you have to do it again. And then artemeter on the bottom. Very easy to give because it's intramuscular, but its absorption also not so good. It's been shown to be about equivalent to quinine, and then artesunate, this new sort of subject of this research. So as a review, we're trying to ask the question, can we get providers to change their prescription habits from quinine or artemeter to artesunate, and then what does that mean? So in terms of methods, we made sure that we had adequate artesunate supply. The Clinton Foundation showed and committed the artesunate supply, and then we also got political buy-in from the ministry. This was important because we would, acknowledging that there are very few doctors in Liberia, be task shifting the administration of the antimalarial to physician assistants. And so basically in Liberia, we had the privilege of having a good relationship. I basically sat down with the chief medical officer and she agreed. We then developed a malaria task shifting decision support tool. Basically what this is a checklist, and it enabled us to monitor adherence to the new standard. You can see on the top, I just sort of filled this out as a guide that the user would fill out the signs and symptoms that made them think that the person had malaria. They would check the glucose because that's one of the side effects, life-threatening side effects of malaria, to make sure that it was above 40. And then they would make the malaria diagnosis. And notice there is no option to even do a smear, right? You either do a rapid test or you don't, and then you go down the line. And then we did 2 weeks on-the-job mentoring. We decided not to teach everyone for a week. What we did is we brought in one physician, a foreigner, and then two physician assistants to work with him. And then we did intermittent maintenance. And what that really means is that we go through the chart, and if we saw that, for example, someone prescribed ceftriaxone when the patient was not hypotensive, then we would basically bring that provider up and say, well, why did you decide not to adhere to the standard? Do you know about some information that we do not? And basically with this type of discussion, people complied rather quickly. And then finally, we left the project. We let 3 months go by, and then we studied 4 consecutive months and looked at what was the rate of adherence to this new prescription regimen and what was the impact. And these are our results. I've marked them 1, 2, 3, 4, just to roadmap where I'm going to go. It was interesting to find that looking at a period 1 year before, that the rate of prescription had not changed at all. The physician assistants and the doctors were doing a good job of diagnosing malaria, but the only difference between August 2012 and August 2011 was in August 2011, people would always order both, incapacitating the lab and using the commodity. We also see in number 2 that we were able to pretty much flip the prescription of drugs. And before, the vast majority in 2011 were given IM artemeter, 91.6%, right? And after that, the flip, we got only 22% prescribed artemeter and 77% artesunate. And of course, artesunate wasn't available in 2011, so that's why it's 0%. We of course asked, well, why do you persist on giving IM artemeter if artesunate is the standard? And in some cases, the physician assistants could not get access, intravenous access. And then finally, it was interesting to see that, we really tried to push that if you don't have signs of sepsis, do not give antibiotics. Now, this is sort of a risky proposition because in 15% of cases of severe malaria, you have sepsis. But I found that in many developing contexts, it's sort of a cannonball approach to everything. Someone comes in and they get antibiotics, they give antimalarials, they get every single thing possible, and it obscures the diagnosis, actually causing more harm than good. We then looked at deaths. You see in one that there are a lot of patients admitted for severe malaria. Again, the criteria is that they're RDT positive, and there are 67 deaths. It's about a 10% proportion of patients that die. And then in 2012, looking at those same 4 months, in an attempt to control for the rainy season, we had more patients admitted, but less deaths, and this was significant to us. So 35% change, which was at least consistent in the direction of the Aquamat study. So the conclusions were that we could get the providers to shift their prescription behavior rather quickly, and we felt that we did that through the use of this decision support tool that pretty much told you what you had to give. We also found that at least that the mortality effects were consistent with the Aquamat study, and that we thought that given that Liberians shouldn't be different from Ugandans, that the government of Liberia should make available artesunate countrywide, as well as usage guidelines or friendly user guidelines. There are many, many limitations to this particular study. One is just the state of the medical record. I think one reason I'm so close to Agustin is that we were cooped up in this room for so long. Basically, a lot of missing charts, illegible charts, but on the other hand, we try to control for that. With the DST, we were able to do very good chart review, the decision support tools. We could see very quickly who was getting the drug and who wasn't. In Liberia, they also keep very good track of records through a patient registry that's filled out at the beginning of the admission process. And we found very good correlation between records in the registry and then records in the book. And then limitation 2 is there's constantly stuff going on in a place like JDJ. People threatening to go on strike, the artesunate supply threatening to go out of any one supply. During the middle of the study, our control redemption hospital, they decided not to participate because we wouldn't give them more fuel. So there's certainly a risk to just say, okay, let's not study this, a little bit too difficult, but at least in terms of supply and shortage of staff. We worked very hard as an organization. We were a $10 million organization, probably one of the biggest implementing partners, and so we could use our influence to remedy some of these shortfalls. So I'd like to thank really the people that came to this presentation, but also my fellow researchers and then the patients of Liberia. Just two things, if there's any reason to contact me, I put up my email. WOWANG, and then also on the bottom, I do write about my experiences as working in global health on that particular space. Thank you.
Thank you so much for that talk. Jason O'Grady, Mayo Clinic. 2 questions for you. One, is there a cost difference between those 2 medications, the standard that the World Health came out with and what Liberia was doing before? And then my second question really is a kind of country comparison. Did some significant work in Togo, West Africa, and found that severe anemia was actually one of the high causes for under 5 mortality in severe malaria. And the problem that we had was kiddos came in with hemoglobins of 3 and 4. We couldn't get safe blood quickly enough to save them. And I didn't know if you found that to be true also in Liberia. Thank you.
Thank you. The price question is very good, and it's pretty much a wash. Quinine is definitely cheaper than artesunate, but it also comes with fluids and has to be given more frequently. So if you look at the price comparison, it's pretty much the same. It's such a great point. You also always have these comorbidities. I think one reason we had good results, the best case scenario, was that on our decision support tool, if someone were to suffer anemia, it would be pointed out, and then they would be an order for transfusion. And since we were a pretty well-resourced NGO, and JDJ was getting a lot of attention from the government, we could give those transfusions. We prided ourselves in being able to give comprehensive care. It was just mostly a lot of times you have these resources, but you don't know how to access them well. But we didn't have that particular challenge of inability to transfuse, when I know that is a difficulty in many, many places.
Hi, I actually work with developing a magnetic separator of Plasmodium falciparum infected red blood cells, because they're actually magnetically susceptible during the infection. And I'm definitely on the engineering side, not on the point of care or human factor side, where I have not actually traveled to countries that have the infection. The device would be like a dialysis system, if you can imagine something similar to that. I understand that it might not be feasible, but maybe it is. What's your opinion on incorporating a dialysis-like treatment, same time and flow rates and all that, into treatment of these severe malaria-infected patients?
Yes, really, at least my particular bias is that what's good for us here is good for what's, for people over there, wherever there is. The key, though, is you have to just make sure that those particular devices are durable, that are sustainable, that you consider things like electricity and voltage and surge. A lot of things, they work really well in theory, but then when you're on the ground, you're like, oops, I don't have a 2-prong plug. I have a 3-prong plug. Just silly things like that. Or, wow, there's no fuel in the whole city. How did we stockpile? So just practical considerations, but if it works here, it will work in Liberia. It will work anywhere.
Let me ask a question of you, and then another question. I think you're talking about as an alternative to exchange transfusion. Are you talking about, like, say, the transfusions you're giving are for anemia, but for severe malaria, of course, in the United States, we sometimes do whole blood exchange. Are you talking about a dialysis?
Yeah, effusion therapy has actually been shown to not be effective and a huge waste of blood, because you can use up to like 5 liters of donor blood, which obviously is not very available. And my system would be using at most maybe half a liter to replace the blood that is.
But so you're talking about
filtered out.
severe malaria as an alternative to exchange transfusion.
Yeah.
You need to do exchange transfusions.
Oh, yes. Thank you for clarifying. I mean, that sounds great, and we were also, confronted with fluid overload in very sick kids, and so yeah, it would be a technology of interest. I just think sometimes in developing contexts, you have to prioritize and decide, like, okay, before I go to that, do I at least have the diagnosis piece picked out? Do I at least have the artesunate piece picked out? And then if you could multitask, great, but sometimes I found like you sort of have to prove the point that you could implement the basics before you bring in something that is icing on the cake.
Yes, ma'am.
Is the government subsidizing the cost of the drugs? Have they owned the distribution of the drugs now, or is it being still supported by the NGO? And is there a kind of an ownership transfer at some point planned?
Yeah, there are people smarter than I am on this particular point, but Liberia 3 years later is much different than the Liberia that I left. When we were there, we supported 6 hospitals, which pretty much meant everything. We paid staff, we brought in the drugs, we transported them, we delivered them, we made them secure, we washed the floors, we brought in the fuel, we manned the ambulances. But now we know that that also is not the best approach, and Liberia has also helped us realize that. So a lot of the interventions now are really in coordination with the government. The government's taking the lead. Now, there's still a problem of revenue, right? People living on $2 a day, they're not going to have much of a tax base. So even though the control and sort of the practice of management is happening at the government level, most of the funding is still external, and it's an issue.
Okay, the next talk is going to be a total switch in gears. It'll be by Dr. Patel, a FLAP course for international orthopedic surgeons. I guess he's an orthopedic surgeon, or which may improve patient outcomes in the developing world, addressing a global health disparity. He's from UCSF.
Hi, my name is Kushal Patel. I'm a research fellow at the Institute for Global Orthopedics and Traumatology at UCSF. And it's an honor to be here speaking in front of you guys. And I'd like to acknowledge my co-authors, one of which is sitting right there, Amber Caldwell. Let's see. So my talk is going to be about a FLAP course for international orthopedic surgeons, which may improve patient outcomes in the developing world. It's an attempt to address global healthcare disparity. I have no financial disclosures. So these pictures, no doubt, represent what you guys have all seen firsthand in the countries you work in. And as a result, injuries account for 10% of the world's death, 11% of the global burden of disease. And low and middle income countries, unfortunately, disproportionately bear the burden of these injuries. And for every death, 3 to 8 more people are permanently disabled. And with more motorized vehicles competing with vulnerable motorbikes and pedestrians, traffic injuries is a growing concern, especially in low and middle income countries, where the care to handle these injuries is not present. And of the 20 leading non-fatal injuries sustained by road traffic injuries, 13 of those 20 are musculoskeletal in nature and make up 50% of these non-fatal injuries. One of the major challenges that the orthopedic surgeons in developing worlds face are open fractures with soft tissue defects that you can't close very easily. And as a result, patients have long hospitalizations, high rates of infection, high rates of malunion, higher rates of amputation, higher rates of disability. Soft tissue coverage procedures for these soft tissue coverage procedures, such as flaps, are used to help close these wounds, a classically plastic surgery skill set that is often unavailable in many of these countries. For example, if you have a proximal open tibial fracture with a soft tissue defect, it would normally be treated with a gastroc muscle flap, which would be rotated over the knee, filling the void. And this promotes revascularization of the injured bone and surrounding soft tissues, reducing both infection rates, non-union rates, and the need for amputations. And as a consequence, we see reduced patient morbidity, disability, and hospitalization times. Now, musculoskeletal injuries accompanied by soft tissue injuries requiring soft tissue reconstruction remains a huge issue in these countries. And limb loss secondary to the lack of soft tissue reconstruction remains an unsolved problem. Traditional approaches to addressing this disparity has been through medical mission models. However, many of our partners wanted to learn how to perform these procedures, learn how to perform soft tissue coverage that would be in essence, limb salvaging in many cases. So we decided to create a simulation-based course to teach limb salvaging, plastic surgery, muscle flap procedures to practicing international orthopedic surgeons. And we would also like to evaluate the effectiveness of this course by assessing participants' reporting practice changes and the outcomes in patient care. So we selected a number of very high impact muscle flaps, and they were chosen on versatility, applicability, the ease by which they could be safely and successfully performed. And in addition, we had case-based didactics, including video demonstration, which was followed with cadaver-based simulation. It's a picture of Dr. Carey, a plastic surgeon from the University of Southern California. He's the director of the course. And he's kind of leading a group of the international orthopedic surgeons through a cadaver simulation. It's an example of our small group didactics. And we hold our course at UCSF's Orthopedic Trauma Institute at the surgical training facility. It's designed for surgical education, and it fits really well with what we're trying to accomplish. So the question is how did we evaluate this course? So we had a pre-course, a post-course, and a long-term evaluation. The pre-course evaluation consisted of demographics. It included patient burden, practice patterns, perceived need of these soft tissue reconstruction skills, and the burden of amputations and soft tissue defects. The post-course evaluation was used to evaluate the confidence of skill learned by these surgeons and the course logistics, which has been very instrumental in the evolution of the course content. The long-term evaluation was used to evaluate utilization of the flaps and the outcomes of flaps performed and the amputations averted. It's a picture of the 2013 course participants this past year in September. And over the past 4 years, we've had 160 participants at the course representing over 27 different countries, and almost 80% claimed a teaching affiliation, which we think is really important because there's a higher likelihood of those individuals then passing on and teaching these skills to residents and other colleagues. We sent out a self-reported flap utilization survey 1 year after these 2012 course participants attended. And we asked them to report back how many times they've performed the flap, how successful they were at performing the flaps, and the amputations averted. With 77% responding back, these 34 participants performed 620 flaps with a 93% success rate, which is in line with the success rates reported in plastic surgery literature. And this is just 1 year of data in a group of about 35 orthopedic surgeons. So if you can imagine, you extrapolate this skill set being used for 20 years with these 35 orthopedic surgeons, this group will avert nearly 2,500 amputations. And we believe that saving a limb can save a family, as these individuals can remain functional, productive members of their families and society. So just to split between the upper extremity flaps and the lower extremity flaps, they were roughly equally utilized. We also taught them how to do some trunk flaps as well, which was less utilized. And sort of focusing on the most utilized flaps, 5 of them account for 80% of the flaps performed. And what we saw was there's a high overlap between the flaps utilized most frequently and the flaps averting the most amputations. There was 5 flaps that accounted for 70% of the amputations averted. And because these skills are taught to orthopedic surgeons that work at teaching hospitals, there's a huge multiplier effect. So 28 other individuals are now performing this flap because they were taught by our participants. And this is just the 1 year. Some of our conclusions that we've been able to draw. So we strongly feel that orthopedic surgeons can efficiently address both musculoskeletal injuries and soft tissue injuries, minimizing morbidity through less delays in care, improved continuity of care, and improved patient outcomes. Orthopedic surgeons also can easily assimilate this knowledge and techniques because they're familiar with the relevant anatomy and don't require as much education. And as a result, these rotational muscle flaps can be successfully taught to orthopedic surgeons in low and middle income countries through its plastic surgery skill, even though it's like a plastic surgery skill. And these taught flaps are being utilized and have been able to avert amputations. Knowledge and skill is sort of disseminated beyond just the course participants. And some future direction, we're going to be conducting a regional course in Tanzania in about 2 weeks in Dar es Salaam at Muhimbili. And we think that regional courses would increase the course's accessibility by allowing orthopedic surgeons from neighboring countries. And it's much more cost effective. And future other directions, we would like to better quantify the burden of orthopedic trauma with associated soft tissue injuries. And hopefully we can also improve the documentations of the flaps performed by our participants. So thank you. If you guys have any questions, feel free to take them.
Hi, my name is Jessica Wilson from the Medical School for International Health in Israel. I was wondering if you could speak a bit to infection and to what role that plays in your training, if any. Road wounds are very dirty wounds, and so I imagine your patients need a program of repeat debridement possibly. So I'm wondering if you sort of incorporate sort of timing of the flaps with respect to infection control.
So that is definitely a concern, and there's definitely, during our course, we talk about, open fractures that are dirty, and the process of debridement, repeated debridement is, a part of this protocol, that they pursue this until sort of the wound bed is clean and then perform the flap. So that's what they've been taught to do.
First of all, thank you for that. That was really interesting. I've got a couple questions. Are these all rotational flaps, or do you do any free flaps as well? That's my first question.
Yeah, so we focus mostly on rotational flaps, partly because they're really easy and they don't require advanced training as free flaps do. Also, the lack of sort of microsurgical equipment in many of these countries sort of is prohibitive to teach free flaps. And so we really focus on the high yield, high impact, easy to learn, easily successful flaps. And those were kind of represented by the lower extremity flaps.
Right. My next question is about your payment structure. How do you pay for this?
So this course is funded by corporate sponsors, usually the orthopedic sort of device companies. The course runs roughly around $30,000. And so for the past 4 years, we've been fortunate to garner this funding. And that's what we've been kind of using to have this course.
So do the individuals have to pay to fly all the way to San Francisco?
So this course is held in tandem with another NGO called Sign Fracture Care. And so our course falls right before it. So the registration is free. They don't pay for hotel. Their flights kind of depends on whether they get funding from their ministries of health or their hospital or some charity organization. I think Sign Fracture Care, the organization, also provides scholarships. So a lot of them don't necessarily pay out of pocket for this trip out here. Amber, you could probably talk a little bit more about that, actually.
The funding, we don't support the funding for the flights. So that's something that the other NGO takes care of, and or most of the people pay their own way, or they get their hospitals to pay. Because there's a lack of continuing medical education in most of these centers, they get sponsorship from the Ministry of Health, or it's considered kind of a credentialing thing. To the cost of the course, the $30,000 is the hard cost that we have to fundraise for. We're grossly subsidized by being part of the institution. The industry support, we actually made a resident pre-course on soft tissue management, which is how I get these companies to come and pay for this. So we've tapped on a whole nother course for residents. So we're part of an institution. It's become a Bay Area regional effort. So we have podiatry residents, plastics, general surge, vascular, and we do a whole kind of boot camp on soft tissue management.
One question, are these all orthopedic surgeons? Because there's not, are some of these general surgeons? Because my experience in several countries is you can't find an orthopedic surgeon. And so did you limit it to orthopedic surgeons, or can a general surgeon from a resource-constrained country participate?
So yeah, it's basically a surgeon that does orthopedic care. Most of these centers that we're partnered with have some sort of recognition of orthopedics and trauma. There are some residency training programs, which are most of our partnerships, but they're essentially all general surgeons that do a lot of orthopedic
So they're
trauma.
not our definition of orthopedic surgeons. They may be general surgeons in a resource-constrained country that attend to fractures routinely. Is that a correct statement?
Yeah, almost everywhere you'll go in the district hospitals, whoever's acting as the surgeon is essentially also the orthopod.
Okay. So-
Hi.
Hi.
Thanks for the nice presentation. My name is Kennedy. I'm a physician from Nigeria. I was wondering, it appears you guys are teaching orthopedic surgeons plastic surgical skill. Have you had any cases of conflicts or tension between the orthopedic surgeons who are taught this skill and maybe resident plastic surgeons at these centers?
From my experience, I haven't heard any particular instances where that's been the case. I think that maybe because a lot of our participants come from hospitals where there is a general lack of plastic surgeons, and so there's really no fight over territory, but that is definitely a concern. I would say that most of these orthopedic surgeons perform on average maybe like 10 to 20 flaps, and so I imagine that they wouldn't be taking, a large volume of cases away from the plastic surgeons. They're generally the easier ones. And I suspect that if there is a plastic surgeon there at a hospital, they're usually trained in microvascular, sort of free flaps, and I suspect that that's their sort of interest, and so they don't mind the simple flaps being done by orthopedic surgeons. But that's just the hypothesis. Yeah, thanks.
Okay, we have 2 talks left. I want to thank all of you for your animated discussion. The next talk will be about fostering individual agency and well-being in women living in the developing world, an evaluation of the Imagine-Kenya initiative. Very imaginative title by Dr. Anita Shankar from Johns Hopkins.
Thanks very much. It's a real pleasure to be here, and I really feel like very much the odd man out because it's not very clinical, but it's more psychosocial, but very innovative, I feel, in any case. So, oops, how do I go back? Okay. So this is going to be talking about an empowerment intervention. It's looking at agency and well-being in women in Kenya. I kind of came to this research actually with over 20 years of working in nutrition and health and maternal health as a medical anthropologist, and really having a significant frustration with how poorly public health programs are actually working. I've done hundreds and hundreds of interviews with women primarily, but also with men, and really trying to understand why our programs don't work as well as they should. So I started really looking at programs or interventions that were focused specifically at fostering agency and empowerment in these women. And when I started looking at the literature, I realized there's so many different definitions of what empowerment is and interpretations around there, especially within the program sector. I want to make one important distinction when I'm talking about empowerment, and I'm glad that Niels Delier also mentioned this as well, and that's the distinction between resources and agency. So empowerment, in the sense of resources such as skills, education, opportunity, and money, is one way to be able to lead to change for people. The other aspect, I think something that's often missing in public health programming, is the fostering of agency. It's the capacity to act. And related to that is self-efficacy, intrinsic motivation, self-respect, and self-reliance. So why is agency so important? And I pulled a quote from a UNDP publication, so I'm just going to read it out because I think it's very clear. The concept of women's empowerment is related to gender equality, but distinct from it. The core of empowerment lies in the ability of a woman to control her own destiny. This implies to be empowered, a woman must not only have equal capabilities, such as education and health. equal access to resources and opportunities, such as land and employment, but must also have the agency to use those rights, capabilities, resources, and opportunities to make strategic choices and decisions. This evaluation actually examines an intervention that's aimed at fostering agency. And I should also say that oftentimes we feel that somebody's agency, you're kind of born with that, but in fact, agency is a nurturable trait. So what's the intervention that we were testing? This intervention is actually a 4-day workshop. It's called the Empowerment Workshop. And it was originally developed by a group in New York, Gershon and Straub, who are non-academicians and actually came a lot out of the human potential movement in the West. It's been culturally adapted and context-specific modifications have been done, and it's conducted by local trainers. It has several different components, but unlike most programs, I'll start with this, it isn't disease-specific necessarily. It's actually individually specific. It starts out with having individuals talk about core beliefs and personal power. They look at their emotions, relationships, sexuality, their body, money, work, and spirituality. Now, the way this intervention is implemented is you get anywhere from 15 to 25 women together in a group. It's their opportunity to do a very introspective examination of their lives, but not just that, but understanding how they think about their world, how they think about their environment, how they think about themselves. There's lots of experiential learning techniques, interactive group sessions, role play, and there's a lot of peer support. As I mentioned, there's the 7 areas of life as well as core beliefs and personal power that it's also discussed. They also, as part of this, learn a very simple process for behavior change. 4 simple steps that kind of get them from the point of where they are now to where they want to go. This evaluation was done in 2 areas in Kenya, one in a Nairobi slum and in Nyanza province, just west. The impact evaluation was done with 213 individuals, 76 who had completed the workshop, and 137 who were awaiting entry into the workshop, so a very similar group of women, primarily women. And we collected socioeconomic data. We wanted to compare psychometric scales of agency and well-being, and we also did some open-ended interviews that were around specific themes, such as economics, changes in economics, relationships, education, and health. The specific assessment tools that we used were the RIF scales for psychological well-being and the trait hope scale that looked at hope and agency. So what did we find? Well, let me go into the analysis. We did a matched pair analysis using conditional logistic regression to see how well these individuals compared related to these psychometric scales. And they were matched by gender, location, socioeconomic status, education, and age. We also did a thematic analysis of the qualitative data on a total of 172 qualitative interviews. So what we found, in fact, were that there was significant differences in specific subscales that we looked at. Specifically, if you can look on the table, positive relationships with others, there was an odds ratio of 2.0, and environmental mastery. And environmental mastery is the capacity to be able to navigate and adapt to their environment. And again, we had an odds ratio of over 2. With measures of hope and agency, again, either 2 to almost 3 times greater improvements. But one of the most exciting things that we found, in addition to the fact that we could demonstrate some differences in these psychometric scales, were the actual changes that they said that they had experienced as a result of this workshop. And just to be clear, there was only these 4 days of the workshop. No additional inputs had been put into the system for these women. So what we found was, on average, there was, in terms of changes in education, so that means the ability to send themselves or others to school, which usually requires a payment. 7% of the controls had mentioned an ability to increase their education compared to 18% in the intervention. Economic condition was almost 3 times higher, 24% compared to 83%. Improved self and family health status, nearly 10 times higher, from 5% from the controls to 55% in the intervention. And improved relationships, almost a 15 times improved reported relationships between themselves and their families and others in the communities. Because the sample was from a group of women that had done the workshop at different times over the course of the year. Some had done it as early as 4 months ago, others had done it up to a year. So we separated those data a bit to see if, in fact, there was a continued improvement in these 4 areas of life as a result of the workshop. And sure enough, that's exactly what they found. So if you look at the dark yellow, you can see the improvements in education, health, relationships, and economics for those who have, it's only been 4 months since the workshop. And if it's been more than 4 months, a considerable increase in all of those 4 areas. But particularly with education, one of the reasons is because the economic condition had to increase enough so that they were able to pay the school fees for their children or for themselves. How could this process be leading to these kinds of behavior change? We're not sure, we're still looking at it, but we believe that it's the first or one of the rare opportunities that women get a chance to ask questions about what's important for them. They're provided a very simple process, very simple analogies that they can relate to that are related to their own self-growth. The nature of the group is structured so that they have peer support and they can continue to continue with the positive behavior change toward their goals that they want in the future. We also have preliminary results from additional studies, both in Kenya and also in India. In Kenya, we worked in one of the most challenging slums in Mathare, and what we found is that there was a self-creation of savings groups where there wasn't before, and after 6 months, 85% of those women had the capacity to pay for rent, to cover educational expenses for their kids, and save. This was with no additional inputs from the local NGOs around. With HIV-positive pregnant women that we're studying in India, and again, this is all preliminary, but we've seen enhanced adherence to antiretrovirals and improved health behaviors. Some of the most exciting work is coming out of the work that we're doing in India around women who are engaged in sex work. The majority of the women in Pune area that we're working in, they were sold into this work by their relatives generally, and they have a debt to pay. And while this was not an explicit outcome that we were looking for with the result, with the use of the empowerment workshop, in addition to the increased adherence to antiretrovirals and increased testing for HIV, TB, and diabetes, after 1 year, 25% of those women who had gone through this process were able to pay their debt and leave sex work entirely. And so what we're saying is that the capacity of this kind of an intervention, if you are able to successfully enhance individuals' agency, you can catalyze tremendous improvements in health and in economics and further thrivability in these populations. One example that I try to bring up as I'm talking about this, because this kind of intervention is rarely discussed in the context of health programs. Sometimes within the context of mental health programs, but not necessarily. A lot of the health and development programs are really focused on basic needs, and I think this comes from a history of, if those of you who are familiar with Maslow's hierarchy, trying to address the basic needs first in order for all those other changes to occur. Things like shelter and nutrition and freedom from violence. But frankly, the women that you're working with, they don't have shelter, they don't have freedom from violence, they don't have food. So what we're suggesting is that we need to turn that upside down and actually begin with awareness so that we're able to impart the capacity to adapt to whatever local environment exists. And for them then to be able to identify different opportunities. Even for the sex workers who had done this workshop, it wasn't that those clinics weren't available every Wednesday. They always were. But for the first time, they had looked at themselves not as, oh my goodness, I don't want to get HIV, but they had the discussions around what it was like to be healthy. And then they themselves decided, I need to be healthy. I'm not feeling well. What do I need to do? Oh, I know that there's a clinic on Wednesday, and I'll show up. So in conclusion, this evaluation supports the premise that facilitating human agency, which is a foundational component of empowerment, is not just possible, it's feasible and at a fairly low cost. Those individuals who live in poverty and other dire circumstances may not have created those circumstances, but they are the primary agents that need to be engaged to be able to change those circumstances for themselves and their society. I think their power needs to be unleashed and fostered in all ways possible, and I think this is one path to do it. Thank you very much.
First of all, I truly want to thank you. Working in Uganda, working in various places around the world, I think there's a complete lack of having medical anthropology take the lead. And I don't just mean showing up, I don't mean just taking part, but truly taking the lead in global health. With a 50,000-foot view, knowing who to help bring to the table. Truly, I would like to empower you and your colleagues to really join us and make us much more effective. Because we think we know what we're doing, but we're not even there, not even close.
Thank you very much.
Thank you. I did want to ask, particularly in Kenya and Uganda, there's the underlying socio-cultural issues having to do with polygamy.
Yes. No, go ahead, ask the question.
I was going to ask, was that something that you were at least considering matching patients on so you could control for it?
So in this case, we didn't, and it is a potentially important issue for sure. Related to polygamy, but also one of the issues that did come up was this issue of inheritance, and I don't know if you're familiar with this, but in Kenya and potentially also in Uganda, when a woman's husband dies, she is to take on a lover, so to protect her own children, and so that they don't die. And so this was a tremendous challenge that women were facing, and this cultural issue that came out of it, and I know this isn't really directed at the question that you have, but by being more empowered to stand up to the possibility of saying, no, I'm not going to take on a lover, I'm just going to take care of my kids, and then being the example of, guess what, I didn't do that, and my children didn't die, so you don't have to do it either. And it's the same thing around FGM as well. So, but anyway, but we'll look at the polygamy issue in terms of the matching. So, but thank you.
Okay, please.
I think what you're doing is really great, and I'm just curious if you think you can teach all of us some skill sets to, is it translatable in the sense of task shifting is what we talk about in the clinical world? Can you teach us, since we're there working on, maybe we can do some of these workshops or have those conversations? I'd be very interested in.
Yes, that was a great question. And also, the intervention itself was developed, as I said, by David Gershon and Gail Straub. They've been using it for 30 years in the United States. So if you want to go to the Omega Institute or Rhinebeck, New York, you can learn this whole process yourself. The challenge was that it was never systematically documented in terms of its impact, and it certainly wasn't culturally adapted or context specifically modified in a developing country setting and then tested to see if it had any impact. So we're in the process of being able to make this more accessible, but certainly from the West, this has actually turned into an initiative. It's called the Imagine Initiative, and it's where we're working in 6 different countries, and we're hoping to get the kind of the base around being able to scale it, because ultimately you'd really want to, very, very simple ideas, very simple concepts to convey. However, the trainer has to be empowered enough so that they don't start giving solutions to others, so that they have to really be a real guide through that process. Yeah, go ahead.
Just out of curiosity, I do understand the control group to some extent, but the content, so you're having the meetings, empowerment meetings, and then I think you argue that the content matters, right? It's not just any content, because you just, okay, but then in order to, this is a methodological question,
Sure.
because I'm totally ignorant about this.
No, it's okay.
But you'd have to have a control group with gibberish content. In other words,
Okay, so,
is there
yes.
such a thing, like with gibberish, like
Well,
you have a
okay,
control group
so
where...
right, and in this particular case, we didn't have an intervention where there was the control, they were just matched by people who were similar in terms of their basic background. However, we are in the process of doing a randomized controlled trial in Kenya around women entrepreneurs and the capacity to enhance, include agency as well as skill building. And in that case, the control intervention was actually around entrepreneurship. So, it was kind of the standard of care on how to empower individuals, but right, I think there needs to be more research around it, but also more programs, so thank you. Yeah.
Okay. Last but not least in this session will be Dr. Dreyfus, who will talk about point-of-care ultrasound training for non-physician emergency care practitioners in rural Uganda, and he's from the University of Arizona. Welcome, Dr. Dreyfus.
Let me see if I can figure out this doohickey. Does this automatically come up, our presentations? Thank you very much. And thank you all very much. At the end of the day, I'm actually astounded there's not 3 people out here. So it's very, very much appreciated. As mentioned, I'm Brad Dreyfus. I'm from University of Arizona. And since about 2009, I've been working with Global Emergency Care Collaborative, which is a Dropbox and Skype organization that is essentially, most of us are academics, but we're housed in different houses of medicine. And so we're not directly tied to one house. And we really try and leverage our academic positions and the ability to work collaboratively to improve emergency care and improve access to emergency care through train the trainer models. And I'll get into that a little bit more. I'm actually here to present on behalf of my team. I am not a fellowship-trained, ultrasound fellowship-trained emergency medicine physician. I have an international emergency medicine fellowship. So I was more interested in how do we actually build capacity. But Lori Stoltz has been very fundamental. She works with me at University of Arizona and has helped develop our curriculum for ultrasound, which we use in the emergency department in the United States on a daily basis, point of care. So the study site is Wanga Hospital, way down here in southwestern Uganda, an 150-bed district hospital that is part of the Catholic Medical Bureau. About 60% of the health care in Uganda is provided by Catholic Medical Bureau. So it's essentially a small NGO hospital. In 2008, some of my colleagues, before we were formally Global Emergency Care Collaborative, raised money and built a 6-bed emergency department. Since about 2009, we've had an ebb and flow of patients, but it's about 300 to 700 patient visits per month. As is true in most resource-limited settings, there are no social security numbers. So I can't tie a visit back to a specific patient, so we count patient visits for logistics right now. So when they built this emergency department, just to give some context, they were thinking they would provide emergency care, they being my colleagues in GECC, through bringing physicians over. Resident physicians specifically, because there's several academic centers, quickly realized it's not pragmatic at all. There's no continuity of care, there's no capacity development. So Mark Bizanzo heroically ended up taking a year and bringing some of us resident physicians over, but primarily himself wrote a curriculum for emergency care that was contextually appropriate. It was initially based on essentially a 500 patient sample when they opened the emergency department, they collected data on presenting chief complaints, diagnoses, interventions required to stabilize and actually treat people effectively. And this is taking place in the context of a district that has 300,000 people, one real district hospital with 4 physicians who do maternity, who do OPD, who do the inpatient wards, and were intermittently, when they could, going to the emergency department. People would wait for care once they arrived at the emergency department before the program, up to 18 to 48 hours to be seen. So anybody who was going to die in that time without acute intervention, they were going to die, which was unfortunate. So Mark Bizanzo and company decided, how else are we going to do this? How do we actually build capacity? Sure, we have mid-level providers in the States, but there's no concept for that in Uganda, particularly with regard to specialties. So essentially got permission to work with the hospital to build a mid-level training program for nurses, enrolled nurses or comprehensive nurses, if you all are familiar with the Ugandan system, that would become hospital employees to work in the emergency department, and then we're also learning in didactics and at the bedside with Mark and others of us who are emergency medicine specialists to eventually practice independently. They evaluate and treat. It became 2 years and is essentially graduated in responsibility. So the first year, they're essentially students. The second year, they are student and teacher. So the juniors are then also taught by the seniors with a board-eligible or board-certified emergency physician who's on the ground, who's mentoring that learning, teaching process and facilitating and helping the seniors refine those skills. Because teaching skills are not necessarily something that are communicated well or taught in a lot of settings, particularly within the old bridge system of memorize and regurgitate. It takes a bit more time to develop you have to explicitly develop the critical thinking skills needed for real clinical decision making unless it's trained. So these are essentially nurses going to emergency care practitioners. We don't call them emergency nurse practitioners anymore because they're going to have to be overseen by a regulating body. And it has to be a regulating body that understands clinical decision making and really embraces it if there's going to be true peer review and regulation, so we can make ourselves as Westerners or the global North obsolete. And that is GECC's goal. So diagnostic imaging. Sure, there's an X-ray machine. There's an ultrasound machine. It's a really nice ultrasound machine. It's behind a locked door. There's one X-ray/ultrasound tech for the hospital, 24/7, 365. So from 8 to 5, 3 to 4 days a week, when the OPD, that outpatient department, is open, you can get X-rays or ultrasounds. Not that they are triaging the most acute patients, because they're not, but you may be able to get them. So we were trying to get creative and figure out what we can do, what's part of our own acumen that we can teach from what we do in the United States or in the Western, in the global North, to emergency care practitioners. So we went on a limb and we really started instituting use of ultrasound. It was initially brought for use for some teaching. Maybe we'd end up using it for real, I say real teaching, but skill building and enabling our ECPs to actually utilize when we're gone the ultrasound. Anyhow, so the ultrasound training was developed. It truly facilitates diagnosis and improves management, as you might expect. And it's based on initial didactic training, and then concurrently, because they are both in didactics and in the clinical realm, same day, practiced on a regular basis and utilized. These are just a couple slides from the pneumothorax lecture, so you can have a sense of how we're teaching it. We're giving them the sensitivity and specificity. I can almost guarantee that's not taught very often in very many settings when you're talking about capacity development, particularly when you're not talking about physician level training. But we try and empower them and essentially treat them as we would want our residents treated and train them the way we would want our residents and our future physicians trained. And down below you can see that there are actual examples of what the images look like, and then they go to the bedside. Basic lectures, mostly given within the first year, have to do with use, when it's appropriate to use. We don't do general diagnostic ultrasound. Point of care ultrasound is specifically yes or no. Is there blood in the belly? Is there not? Is there an intrauterine pregnancy? Is there not? Is there a pneumothorax? Is there not? Is there a pericardial effusion? Or is there not? We try and keep it as straightforward as possible in our own practice. Otherwise, we send a radiology in the United States to get a formal ultrasound that's more diagnostic. And it's the same concept here. The basic physics, we have to also teach. The EFAST, which is the extended focused assessment with sonography and trauma, looking for blood. We do a lot of ultrasound-guided nerve blocks, which is not something even in the United States we've embraced as much as we should, but pain control is a major issue, and access to narcotics is a huge issue in resource-limited settings. So we actually use lidocaine, which is much more readily available. We take a look at the heart with echo, trying to see if there's pericardial effusion, and if there's good squeeze. We're not getting more technical than that. We're keeping it very basic. Hepatobiliary, looking for gallstones, and looking for an inflamed gallbladder, because it might need pulled out, and we can get one of our 4 physicians to come in and take out a gallbladder. If there's blood in the belly, and they need a laparotomy, that's when we call them in and they take over. So they're already dispositioned, they're going directly to surgery. To look at the lung, so you can put in a chest tube, and soft tissue infections, looking at how you can drain abscesses and obstetrics, as I mentioned. Advanced lectures typically come the second year. So, performed during shifts, as I mentioned, it's truly integrated, and it's used real time in the emergency department on patients. We also are assessing them through proctored bedside exams, similar to the objective OSCE. It's essentially where you have a standardized patient. I'm trying to remember what it actually stands for. I apologize. And our main course is taught all by ultrasound fellowship-trained emergency physicians. That's who designed it. When many of us go over and who use it in our daily practice, we reinforce it, but we leave the mainstay of the teaching to the folks who end up teaching us and our residents as well, just to try and keep things consistent. Essentially, the way we've started evaluating this presentation is one small part of a much larger picture of our assessments of our program, not just the ultrasound, but of the whole entire training program. But the first thing we want to do is figure out, are they actually using ultrasound? Are they initiating the use of ultrasound in our patients? We collect data on every one of our patients coming through, including demographics, chief complaints, procedures that are performed, all the diagnostics, and discharge diagnosis, disposition, as well as 72-hour follow-up, which we follow up with patients via phone, as well as in the wards if they are admitted. So we actually have some decent data. But we're finding they're using the FAST, or the abdominal ultrasound, the most. It's because trauma is becoming increasingly common, as was explained earlier. Looking at echo, we have plenty of people with heart failure for multiple different reasons, and looking to see how the squeeze is, as they put it. OBGYN, for obvious reasons, you're looking for ectopic pregnancy. You want to make sure you have an intrauterine pregnancy if you have a pregnant person who's having vaginal bleeding. Thoracic, you can look for effusions, you can look for pneumonia, you can look for pneumothorax, renal, biliary, etc. And that's in decreasing order. Once you start getting into aorta, appendix, lower extremity clots, you get into more advanced studies, or what we consider more advanced. So they are scanning less. This is over about a 2-year period. And it has an asterisk on it because we say recorded. Even in our own shops at home, I call the emergency department shops, I apologize. We use the ultrasound real time. We may not record every ultrasound we do, only for the yes-no questions we really want to answer. So this really, truly is an underrepresented sample of how much they're using the ultrasound. This is an example of they're looking at the right upper quadrant, likely at the gallbladder, to try and rule that out as a source of abdominal pain. Limitations of this study generally is, like I said, not every scan is recorded. Multiple scans will be performed on one patient. So you may have a patient with a certain clinical situation, but they're getting an aorta, they're getting a renal scan. We're also taking a look at the heart to see if there's a pericardial effusion. There is a learning curve, and so as the ECPs get more comfortable with ultrasound, they tend to use it more, but we're not able to capture that in the way we've collected our data thus far. And then formal ultrasound review by ED fellowship, trained emergency physicians, has been intermittent. And there's actually one of my colleagues presented a poster about the number of scans that were done being based on if they're actually getting almost real-time feedback, or if they're getting feedback. People want the reinforcement. Are they doing it well? Are they seeing what they should be seeing? Are they labeling it with what they should be labeling the images with? Are they missing findings? And that all comes with the ultrasound review and the tele review. So our general conclusion is that in the rural resource-limited setting, bedside ultrasound can be taught to non-physician emergency practitioners to diagnose and manage a myriad of emergency disorders. There is a lot more data that we are producing that will further reinforce this, but we keep talking about training physicians and only physicians in specialty care. However, if we're talking about really trying to manage acute care in a population that is 80% rural, Uganda, 80% of the our population lives in the rural areas. We don't have physicians in those areas. There may be one doctor for every 18,000 people in the population, one nurse for every 900. So truly, there's essentially an order of magnitude difference. So we need to be more innovative with who we're training. And not just training, but training as trainers, and truly enabling with the idea of built-in obsolescence for us. We've had a couple very enthusiastic ECPs who've been pretty much scanning everybody, looking for everything. And a patient coming in with intussusception, which for those of you who don't know, is essentially a telescoping in the bowel. You get this characteristic target sign, which has been diagnosed and was submitted to Lancet and published. We have another case series that we're going to be putting out there of perfed intestine from typhoid. So it's not just trauma, it's also infectious disease where emergency care is really effective. In emergency medicine, we don't do a very good job of framing emergency medicine as a public health intervention. But in some of the analyses in Uganda, at least, 61% of the under 5 mortality could be addressed by stabilization with emergency care, where patients are then reconnected with primary care as well as malnutrition programs. So emergency medicine can't stand on its own, just like most of the silos of research and programs can't and shouldn't be expected to stand on their own, even if we talk about them individually. Anyhow, future and current directions, we're really working on our quality assurance and assessing the impact of tele-review. That's coming out of UMass. We're publishing case series. We're having more robust research generally with regard to interventions that we can use and trainings. As we increase our number of ECPs, we increase our N and our ability to really have the power, I guess I should say, to do the appropriate studies we'd like to show definitively that their skills are enhanced with ultrasound. And what's beautiful, the most empowering part as someone who spends a lot of time that's volunteered and leveraging time between academia, is that the ECPs are taking the initiative. It's fantastic. They are wanting to do the trainings. They are wanting to teach. They are wanting to publish. They are wanting to write. And all we have to do is continue to support them so they can run with it. And that's just, I think, analogous to most of the train-the-trainer programs that we're starting to see pop up. And we are now going to need our communities to really speak up and have the ministries of health and the World Bank and these other funders really better support workforce development and sustainable workforce development. Anyhow, I look forward to having what we do in the Global South really start to impact even more so the Global North, because we do have so much to learn. Thank you for your time. And here's information about GECC. Please, if you have any questions, if people would like to get involved, if you know of folks who are emergency physicians or residents, we are really looking to grow GECC. And the wonderful part is that as academics, we can bring academia to what we're doing in the field, and it really truly benefits everybody because we're able to advance our colleagues in Uganda's careers as well. Please.
Thanks, Brad. Really appreciated the presentation. So one question I had, if you could speak to the protocols by which these folks are scanning folks when they come in. I think one thing you mentioned is some of the very enthusiastic people are scanning everybody. And I think you and I know the old saying that, you know, doing an unnecessary test, not only does it cost more money, but it's kind of like picking your nose in public. If you find something, what do you do with it, right? So just wondering if you could comment on that, please.
First of all, Dr. Lowe, I truly appreciate your commentary and your sense of humor. It's a great question. And like I said, we really strive to treat our ECPs as we do our residents at home. When I have a patient who comes in with general abdominal pain at University of Arizona Medical Center, I will encourage a resident to take a look at the aorta, take a look at the kidneys, be general. You need to develop a bell curve of experience of what is normal and what is not, and we will review those images. We will talk about those images. When you find an abnormal finding, then you address it as you need. If it's not clinically relevant to the chief complaint or the symptoms, then you may not need to address that now, but you can get them plugged in, I like to say, or connected to primary or ongoing care. I hope that addresses that effectively. We often find people with gallstones may be in the neck of the gallbladder. They're not really having pain in the right upper quadrant, more to their left flank, and oh, by the way, they've got hydronephrosis or backed up ureters from having kidney stones distally. We refer them to surgeons for an outpatient evaluation for their gallstones. They may or may not have actually caused them problems for them. But for the learners, that can be very empowering to find something and to really connect that didactic teaching with what they're finding at the bedside. But it's an excellent question, and thank you.
Hi, I was wondering if this is something that you think might be useful to include in the general nursing curriculum, or if you think it's more better served in teaching it to people who are already working in emergency care.
You ask a wonderful question, and I think since we're still talking about hospital-based emergency care, and we're talking about this training in the context of a 2-year longitudinal curriculum with oversight all the way through, and graduated education. This is very different than a short course where you go into a community and you teach someone how to do crown rump length, how to do femur lengths, trying to come up with gestational ages, making sure there's all sorts of applications for ultrasound. It's very different than a short course, and that's why I couch it in terms of what we are doing more generally. Because oftentimes, and I don't mean this to discount the use of technology or the teaching of technology in other contexts, but truly there does need to be an ongoing quality improvement, quality assessment, refreshers, CME component, which is not inherent in the education process of most of the developing world. It's just not. So when we go in being like, we're going to do a short course, we're going to change their practices, even if we can find an ultrasound to leave with them, what can happen, and anecdotally, people tell me that people will go do multiple of these short courses. They'll go buy an ultrasound, or they'll find one or get one donated, and then they'll open up a shop where they're, for $10 or $5 worth of shillings, they'll scan 40 people a day and get rich from it. Meanwhile, they don't really know what they're looking at, but they seem like, because they have the technology, they seem like they have the expertise. And like Dr. Lowe was indicating, can cause a lot more harm than good, because it's not in a more controlled educational environment. I hope that answers your question.
Okay, thank all the speakers. It's after 6.
you all.
Thank you so much for participating.
Enjoy your evening.
Goodbye.